there are definite special considerations when it comes to cannabis use in women. My name is Genester Wilson-King. I'm a physician. I'm a board certified OBGYN, also the co-vice president of the Society of Cannabis Clinicians, board member of the Doctors for Cannabis Regulation, and I am a cannabis clinician.
You're listening to the Curious About Cannabis podcast. Hey everybody, this is Jason Wilson with the Curious About Cannabis podcast. Thanks so much for tuning in once again. So today I'm really delighted to be reconnecting with a friend of mine that I met several years ago that's doing really interesting work in Florida, Dr. Genester Wilson-King, who is an OBGYN and involved in so many different aspects of the clinical use of cannabis that we're going to get into. But welcome, Dr. Wilson-King, for coming on the podcast. Thanks so much for joining us.
Thank you, Jason, for inviting me. I think we reconnected on LinkedIn. I think that's how we reconnected after not seeing each other for the past 4-5 years or so. So this has been fun.
Yeah, we have a lot to catch up on, which is always really exciting. And to give people a little bit of background on your work, and I hope I don't misrepresent it at all, but you've been doing all sorts of work in women's health for a while, but you've had, different levels of focus. You're not only, in general in OBGYN, have been working in women's health for a while, but you're also an expert on the concept of bioidentical hormone therapy. Isn't that right as well?
Yes, definitely. Yeah, I had a conventional OBGYN practice for many years, and my practice began transitioning to more of an integrative wellness practice, which is the focus the past 10 years or so. Because I didn't like pharmaceuticals, and I saw my patients as they were aging and going through life just increasing the number of medications they were taking. And I was a firm believer in, you know what, if you eat right, if you exercise and really take care of yourself, you shouldn't have to go through all that. Sure, there's various stressors in life and various times when you need an antibiotic or something like that. I'm not knocking that, but I do believe that there's a better way to do this. There's a healthier way and a more graceful way to age. We should not have to look at aging as, okay, by the time I'm over 50, I'm going to be taking 10 or more medications, and half of them are going to be because of the side effects of the other half. And what a way to go. So essentially what I do now is I assess where men and women, so I focused on women, and then the women said, "Can you fix my husband? Because he can't keep up with me." So then I branched out into men because of the demand of my patients. But what I do is assess where men and women are on the health and wellness spectrum, and then help them get to where they want to be. I use nutrition, lifestyle behavior modification, supplements when necessary. Although, as a caveat here, I'm not one who thinks you need to take 10, 15, or 20 supplements a day either, because there's nothing that says that supplements actually work. We know that these vitamins and minerals in food are helpful and beneficial for certain things, but we don't know if you get those same benefits via the oral capsule supplement route, or even if it's a liquid. So supplements when necessary. Bioidentical hormones are a large part of my practice. Herbal and cannabis regimens. Cannabis was a nice complement when I began to introduce that. But all of my programs in the practice are individualized. And I've been doing bioidentical hormone, or been using bioidentical hormones in my patients since the 90s. So I was one of the early users and believers in bioidentical hormones.
And how did you come upon that? And then we'll get into how you came upon cannabis, after that. But how did you stumble into this world of bioidentical hormone therapy?
It stumbled upon me. I was managing my patients the usual way. If they're a woman of reproductive age and were having symptoms consistent with hormonal imbalance or
Hmm.
hormonal dysfunction, put them on birth control pills. If they're
Yep. Yeah.
if they're menopausal, then you put them on the pharmaceutical hormones. And then there was PMS.
Hmm.
And I just didn't have an effective way of managing women with PMS. And I had PMS myself. So
Sure.
I said, okay, there's got to be a better way to do this. My local pharmacy had a really dynamic uh, pharmacy tech who gathered all this information about progesterone and
Hmm.
bioidentical hormones and whatnot. She was looking to expand the pharmacy's compounding section.
Mm.
And she took these, and this shows you how long ago this was. She had cassette tapes of,
Yes.
of seminars and talks about bioidentical hormones. And she went to every OBGYN in town and delivered all this information, books, brochures, etc. And it turns out I was the only one who looked at the stuff and read it. And I picked up the phone and called her and said, "We need to talk about this. I really want to try this on my patients." And of course, what I do is I will try things on myself
Hmm.
before I try them on my patients. Number one, I want to make sure it's effective
Yeah.
for what it says, what I'm telling the patients it's effective for. Number two, I want to make sure I can feel all the side effects or find out what you're
Mm.
supposed to feel, et cetera,
Mm.
et cetera, et cetera. So I can share that experience with my patients.
Right.
And number three, it really gives the patient confidence if they know you've tried it too.
Hmm. Right.
So I tried a lot of these things, especially the solution for PMS, and it worked like a charm.
Mm,
So
wow.
I started utilizing that in my practice and quickly became known as the hormone doctor. If you have any issue with hormones, you need to go see Dr. Wilson King. So that's how I got into bioidentical hormones. And I started going to conferences, listening to lectures, and talking to people who knew more about it than I did. This was not something discussed in medical school.
Hmm.
And so it had to be self-taught. But along the way, I always knew, and this is the way I practiced medicine, I always knew that we're more than just our physical body. We're a spirit that has a soul that lives in a body. So you really need to address all three. They all three need to be in balance in order
Hmm.
for you to be well. So I would ask my patients about stress and
Yeah.
stressors,
Yeah.
and I would ask them what they do for relaxation and meditation. What do they do? What is their spiritual life like? Not really, uh, not focusing on any one way.
Sure.
I,
Yeah. Hmm.
I just have some spiritual life. That's all. Some way of connection with nature, with the universe,
Things
with
bigger than
love,
yourself.
things
Yeah.
bigger than yourself. Yes, things outside of us that love us, etc.
Hmm.
So that's how I approach things. And then when I started doing bioidentical hormones, I started looking at things like that, and I put together a program for myself to teach patients how to do better, how they can cope, how they can manage stress besides drugs. You
Yeah.
know, it's amazing what you can do to your body
Yes.
if you
Yes.
treat it right. The body is such a wonderful instrument that was created to really take care of itself. If
Hmm.
you treat it right, put all the right things in it, do the right things with it, and do that all important self care, which we neglect, and women
Yeah.
especially neglect. We take care of everybody else and leave ourselves for last when it really should be the other way around.
Yep. Yep.
Because if you're going to be able if you want to be there for your family and others, you've got to be in good
Yes.
condition yourself. So we have to
Absolutely.
learn to take we I had to teach patients, and I had to learn that myself before I could teach it, that you got
Hmm.
to take care of yourself first. So one of the things I did back in the 90s is uh, I was a single parent with two little ones, and
Oh,
um, oh, it was so much fun. But
mhm.
being a solo practitioner,
Yeah. Yeah. Oh,
OBGYN,
yeah.
and doing that, oh my goodness, I was really burning the candle at both ends in terms
Yeah.
of being up and doing and moving and grooving. So one of the things I did is when I got home from work, I would go into my room and sit and meditate about 30 minutes. Now, I couldn't start off doing meditation for 30 minutes.
Sure.
You
Yeah.
kind of, it's like being quiet
Yep.
and paying attention to breath. And of course, within the first minute, your mind is going other places, and then you just kind of bring it back, settle it down.
Exactly. Mm.
And what I did is I told my kids, okay, mommy's going to go in this room for 30 minutes. Now, unless you're bleeding profusely, don't knock on the door, because you know what's going to happen when mom comes out. She's going to be a more fun person that night. So just
Yep.
let her have that 30 minutes so she can chill out and relax.
Yep.
And then we'll have a good evening. We'll get dinner ready and we'll, go from there. So they started to learn to, okay, let mommy take 30 minutes and then we're good. So it was good. But of course, all that changes when they're teenagers.
Yeah. A lot goes out the window then, right?
Oh my gosh. Everything is an emergency. There's always this drama.
Oh, yeah. Yeah.
And then there's always, okay, after about a week of me being home every night, my my daughter would say, Mom, you're never there when I need you. You're never there for me to talk
Oh,
to.
gosh.
And I said, okay, let's look at that. Did you get to watch all of your favorite TV shows this week? Yes. Was I home when you were watching them? Yes. Okay. So if you needed to talk to me, you could have come and talked to me, right? And she would
Yep.
just, you know how kids do, roll their eyes, suck their teeth, and she's like, Mom.
Like, well, put it in
Yeah,
perspective. Yeah.
exactly. But it's all good. It was just all fun. But
Well,
yeah.
it's really cool to hear you talk about that, learning the need to take that little bit of time to recalibrate
Hmm.
from basically from one world to the other.
Exactly.
Because that's something I'm currently learning right now. Um, now that we have a baby, and especially because I'm working from home all the
Mhm,
time. And
mhm,
I think this is something good for people to hear if they are working from home a lot right now, because I know I've been working from home longer than the pandemic. So I kind of had to get accustomed to how that affects your psychology when you're working from
mhm.
home and trying to separate work from family, and all these different things. And I have a lot of friends that have been struggling with that since they've been, having to stay at home and work more. And that's the biggest key that I found that helps me is if I can have at least 15 minutes, ideally 30 minutes, when I finish doing all of my work in the home office, if I can just sit here and just kind of mentally prepare for what's about to come next and just like you said, focus on the breathing, just kind of
Mhm.
come into the moment. You can almost feel the tension in your head start to like loosen up.
Yep.
Um, and if I'm able to do that, then stepping out of the office into the world of a screaming baby and,
Mhm.
stressed out wife and, all of these sort of things that, I have to come into to help with, I can do it with a much better attitude and with a much better energy
Yes.
than if I'm like rushing to get through work and then I rush to get out there. And then I'm frustrated and, all these different things. I think that's a really valuable lesson.
Yes. It really, really is. It changed my life. It really did. And once you know how the 15 to 30-minute break
Hmm.
affects you, you can do it when you need it
Yeah.
as opposed to just only certain times. You can, hey, if I'm preparing to go in front of a big audience or something, or I'm going into a
Hmm.
very important meeting, I take the 15 minutes before the meeting or so just to go into that quiet space
Hmm.
and just chill so that I can be calm and focused when I go into the meeting or whatever it is I'm about to do.
Absolutely, yeah, and part of it too is kind of having faith in your body and brain
Mhm.
to do what you know it's capable of. Because like some people struggle with getting into that space because they're worried that, like for instance, situation like you just mentioned that I've been in as well. If you're going to speak in front of an audience or go into some situation like that where you feel like you need to be preparing all the way up
Mhm.
until the last second,
Mhm.
a lot of that is a lie in our brain because you already know it.
Ex
You already know what you need to say. The key is getting your anxiety, your stress, all of that sort of stuff out of the way so that you can just let your body and brain do its thing,
Yep,
and you'll remember better. There's all sorts of benefits, but it takes some faith, I think, to really trust that process.
exactly. It really does. And you learn that as you go. You do
Yeah.
learn. It certainly isn't something that, okay, I'm going to do this the first time and then after that everything's supposed to miraculously be all right.
Hmm.
No, it takes time, and what you realize is the less effort you make towards
Hmm.
it, the easier it is to do.
Yes. Yeah, like quicksand, right?
Yeah, exactly.
Yeah. Yeah.
Exactly.
And how did your journey, so in the 90s you're learning about hormone therapies and stuff, which, as an aside, something I wanted to comment on, you were talking about how a lot of that work wasn't taught in medical school. And isn't that such a funny juxtaposition with cannabis and the endocannabinoid system and all these other
Mhm.
things that also are still not really being taught in medical school? There's some CME classes and stuff now that are great that you're probably involved in. Um, but there's still not a lot of widespread physician education on these topics. So I just wanted to like pin that in the air that that's a very interesting dynamic that before you got into cannabis, you had already sort of been through this kind of dynamic with
Yes.
with a totally different, not totally different because they're related, but seemingly different topic altogether. So how did that proceed into you discovering cannabis as a physician?
Well, to follow a little bit of what you were
Hmm.
saying, I cannabis and hormones are really similar, and we'll get
Hmm.
into that a little bit later. But I believe my hormone preparation, bioidentical hormone preparation, was a great foundation for my cannabis not learning, because that also had to be self-taught. I didn't learn about
Yeah.
the
Mhm.
endocannabinoid system in medical school and whatnot. So about 2005, well, of course, I had colleagues in California,
Mhm.
and they were the first to pass a law in 1996. And the early 2000s, I started having more colleagues that were talking to me about cannabis. So, about 2005, I read the first book I ever read about cannabis was Lester Grinspoon's
Oh,
The
yes.
Marijuana, the Forbidden Medicine. And the reason I read it is because he had an interesting story in that he was a psychiatrist at Harvard, and he set out to prove how bad cannabis
Mhm.
was for you by doing this research. And he found the exact opposite and found that it was really a collection of patient stories on how the use of cannabis impacted their life. And there was one section on the elderly that really stuck out. There was plenty of anecdotal stories about the elderly and how they went from being homebound and lonely and whatnot to being much more social and being able
Mm.
to go out in public and do more things without feeling all the pressures of being elderly and alone.
Yeah.
So there was this one story of a man. He was 82 and he had six siblings. There were seven of them all together. They grew up on a farm in Kentucky and they grew hemp. And they had hemp tea. Now, when I say hemp, it's in quotes.
Yeah. Yeah. Right.
They had hemp tea, and their parents used the salve if they were
Mm.
injured or cut or
Hmm.
anything. And this family grew up surrounded by hemp and always used hemp throughout their lives. And all of the siblings, they were in their upper 70s, lower 80s. They none of them were on any medications. They were all active. They all were sharp mind,
Hmm.
maintained their sharp minds, and still worked on the farm and did things and were mobile and felt healthy. Didn't have any medical problems. And they attributed that to hemp, having hemp a part of their diet. And when
Yeah.
you think about it, when they when this in the mid to late 1800s, actually mid 1800s, cannabis was the most widely prescribed medication
Yeah. Yeah.
in this country. The salves, the tablets, the teas, all sorts of things. You can go to the apothecary, which was what they called the pharmacy back then, and get whatever you needed. So we took it away in 1937. The government took it away. So we've gone now, this is probably the fourth generation
Yeah.
without hemp in their diet. And we have widespread autism, we have fibromyalgia, we have chronic fatigue. We have all these various conditions that don't respond to conventional medicine
Hmm.
very well, mediocre at best, but seem to really respond well to cannabis.
Hmm.
What
And they're
does that say? You
and
know,
they're largely chronic
they
conditions.
are chronic conditions,
Hmm.
exactly. And I love Western medicine. Don't get me wrong. If I have a bladder infection, and you give me that antibiotic, I will definitely take it.
Yeah.
But when it comes to managing chronic disease, Western medicine isn't the best because medicine shouldn't be taken over a long period of time, years upon years upon
Yeah.
years, just to keep taking it because it does do something to you.
Yeah.
And it will
Absolutely.
have negative consequences if that's what you do. So that whole, anyway, that book led me to, I just dove into cannabis research, went to California, visited some colleagues, watched what they were doing, and just said, wow, cannabis is really a good thing. We already have this receptor system in our bodies
Yeah.
for cannabis. Now, how much more of a message do we need that this is meant to be for us? It's meant to be ingested. It's meant to be used
Well,
for
and
us.
what blows my mind that when I interviewed Ethan Russo, we talked about this, but how mind blowing it is that CB1 receptors are the most dominant receptor in the brain of their type, of these G protein
Mm-hmm.
coupled receptors, which are a very common type of receptor. So to
Mm-hmm.
say that CB1 receptors are the most dominant of their type in the brain, like that's a huge deal. And it shows how um, we've missed such a big piece of human physiology throughout the past several decades, 100 years or so, as modern medicine as we know it has been developed, which is really interesting to think about. That we're trying to treat, like mental health, for instance, trying to treat mental health, but we're ignoring CB1 receptors,
Right.
and they're
It's
so
like,
dominant.
okay, mental health, brain, CB1 receptors, brain. Okay, put those together. How do you leave that out?
Yeah,
you
yeah.
know?
So
Yeah.
it's a weird situation that most of the physicians that I've spoken with that are kind of on this level that have been studying for the past, several decades, trying to wrap their heads around this. I hear this message echoed of like, oh my gosh, we've developed so much of our modern Western medicine, totally ignoring one of the biggest physiological systems in the body.
That's right. That's right. The endocannabinoid system is the most widespread receptor system in the body. That's exactly right. And it was discovered in the early 90s.
Yeah.
And until a few years ago, still wasn't taught in medical schools. There are several medical schools now, one of which is my alma mater,
Oh,
Thomas
nice.
Jefferson in Philadelphia, Pennsylvania. I am a Philly girl.
Nice. Shout out.
Yes, shout out Philadelphia Eagles, Philadelphia 76ers. Yay. Um, and Temple, actually, two medical schools in
Hmm.
Philadelphia are teaching
Oh, wow.
about have courses on the endocannabinoid system, and Jefferson is involved in research. So we're getting there. We're a long way from where we were again, but we're
Mhm.
not where we need to be. It's getting there.
Yeah.
What I want to see in the future is that there'll be a cannabis clinician residency,
Yes. Yeah.
which would
Hmm.
be fantastic.
Yeah. And I mean, imagine we're already making so much progress in understanding how to use cannabis in a more sophisticated way clinically, just based on the experiences of people like yourself that, have had to kind of dive in the deep end, so to speak, and figure it
Hmm.
out yourselves.
Hmm.
Imagine the progress we'll make when we have, so many more physicians on board
Yes.
that are at least working with not just the plant, but all of these different expressions of the plant and these products and everything. And you know, I I understand the limitations of clinical research and the lack of incentives to do a lot of what requires heavy funding to do some of the research. But there's so much we can just learn from the stories that physicians can share about their clinical experiences. And I mean, obviously, clinical research is very important, and it'll happen. But there's also a lot of wisdom to be gleaned just from understanding what physicians are seeing in their patients, and what patterns they're noticing. So it's exciting to me to hear that there are schools out there now that are teaching about this and empowering physicians with a greater toolkit to work with, because it's gonna do great things just for expanding and maturing our
Hmm.
own perception of this plant and how it can be used.
Exactly. Exactly. I'm excited about what the future is going to bring when
Yeah,
it
yeah,
comes to that.
me too. I mean, it's already kind of like a series of tidal waves of information that's coming in now, just with the slight loosening of regulations. So yeah, it's going to be really exciting to see. And segueing into this topic of clinical outcomes, I guess we'll get into kind of the meat of your work, so to speak, which is um, when you're working with patients. Um, what are you typically treating with cannabis or cannabinoids, and what sort of outcomes are you typically seeing?
Um, you know, many women's health conditions, and this is really the key, many women's health conditions have multifactorial
Mhm.
components,
Yes, yes.
including mood. You're familiar with that, right?
Oh, yes.
Pain,
Yeah.
poor sleep,
Yes, yes.
and hormonal dysfunction that just wreaks havoc
Yeah.
in all aspects of life. So, the capacity of cannabis to act as an anti inflammatory agent, a muscle relaxant, a mood enhancer, a sleep remedy,
Mhm.
and a pain reliever all at the same time make it ideal for women's health conditions. And that's how I look at it. If I have to be careful what I say because
Yeah.
I
I totally
would. I
understand.
wish I could treat every health condition, every woman's health condition with cannabis, some form of cannabis product. Even if they just drink cannabis tea every day,
Mhm.
it can be helpful, particularly for mood and hormones and whatnot. Because the female reproductive system is actually the the brain has the most cannabinoid receptors, but the female reproduction system has the second highest uh,
Mm.
receptors and functions of the endocannabinoid system. So that it interacts directly. The endocannabinoid system and hormones interact together. There's a bidirectional component
Mhm.
there. One influences the other, and it's actually quite fascinating how that happens. And estrogen is the hormone that modulates the endocannabinoid system and hormones.
Yeah.
So I see cannabis affecting and helping all sorts of female conditions, uh, PMS, dysmenorrhea, meaning menstrual
Mhm.
cramps. It's wonderful for endometriosis. And
Mm.
therapy today for endometriosis is
So
medical
abysmal.
or surgical, and exactly mediocre at best, usually ineffective. And if it
Often
does help, it stops. It's short lived. The help is temporary, and then you're back where you started again.
and it's often misdiagnosed or
Yes,
undiagnosed.
yes, exactly, exactly. And that's how some women get labeled with a mental health problem because
Oh god. Yeah.
endometriosis is hard to diagnose. And if they keep doing these tests, like you do a pelvic ultrasound, you do
Mhm.
blood tests and whatnot, and everything looks normal, then you think, okay, she gets labeled as someone with a mental health illness, and then put on an antidepressant or some other uh, medication
Mhm.
or antipsychotic and goes on her way. And really, it's endometriosis that's not diagnosed and not treated. But cannabis does wonders for endometriosis, and endometriosis is one of the clinical endocannabinoid deficiency
Mm.
conditions. I've talked
Fascinating.
with Ethan Russo about that. He and I have had a conversation about it, an email exchange, and it's definite. It is an endocannabinoid deficiency. And he sent me a few papers to read, a few articles to read about it, and it's fascinating. So, cannabis is effective for that,
Do you
for
mind
endometriosis.
do you mind describing, in case anyone listening is totally unfamiliar with endometriosis? The only reason I know about it fairly well is because someone in my family has it and has been through the ringer with it. But do you mind describing what endometriosis is, in case anyone's unfamiliar
Not
with it?
at all. Endometriosis is it's a disease commonly that occurs in women between the ages of it's got a prevalence of about 10 to 15% in women of reproductive age. It's
Mhm.
actually the presence of endometrial tissue. Now, the endometrium is the inner lining of the uterus. That's where your
Mhm.
menstrual flow comes from. So that's called the endometrium. And sometimes that tissue can get pushed into the uterine wall or pushed
Mhm.
out of the uterus completely and implant on the intestines, the tubes, the ovaries, implant anywhere in the pelvis or abdomen. And that tissue still responds to hormones, and it causes a chronic inflammation at the site of implantation. So women have pain. We really don't know what causes endometriosis, but we do know that it is a disease of contrast, meaning it is benign, but it can be invasive, meaning it
Mhm.
can penetrate the uterus and go to the tubes
Yeah.
and other places, just like a cancer would. But it's not, but it's benign, it's not cancerous.
Mhm.
It's also cyclic hormones, meaning your estrogen levels go up and then they come down, progesterone levels go up and then they come
Mhm.
down. Cyclic hormones stimulate this growth, whereas
Ah.
if you're on a continual hormone level, that suppresses growth. So it's a fascinating disease that we're still learning about, and it really affects the patient significantly. It affects the families, the
Hmm.
partners, and the carers of people with endometriosis, and it affects the patient's social and economic participation, their physiological, mental, and psychological health. It
Yeah.
really can be impactful. So it's and the symptoms are usually dysmenorrhea, that's uterine cramping during the menstrual period, before the period, after the period. Chronic pelvic, back, and abdominal pain is just something that is very common in women with endometriosis. And the pain is often diffuse and poorly localized. Like, you
Mm.
know how sometimes you ask a patient, okay, where is this pain? Point it out
Yeah.
to me. Well, they can't. And
Hmm.
that's part of what leads them to be labeled a mental health illness, because surely you can tell me where the pain is, that sort of thing.
Hmm. So,
So,
so doctors are just assuming these women are hypochondriacs, basically.
yeah, or hysterical.
Yeah. Yeah. Yeah.
It's anything along those lines.
Yeah.
Anxiety. You got a generalized anxiety disorder or
Hmm.
something to that
Sure.
effect.
Hmm.
And unfortunately, we're quick to label women that way. That's why
It's true.
women
Yeah.
don't get diagnosed with heart disease as early as men, because their complaints are attributed to anxiety
Yep.
or emotional hysteria and things like that, things that men like to attribute to women.
What you just said, I think, is important to highlight because some people may not realize what some of the statistics around healthcare say about this issue. But women are far more likely to be disregarded in emergency rooms and in general healthcare settings when they are trying to get help over things. And just in general, just being a woman, statistically, you're less likely to be taken seriously
Yep.
in a healthcare setting. And then if you're a woman of color, it gets even
Mhm.
worse.
Exactly.
And
Exactly.
and this leads to a very underappreciated and underrecognized issue within our healthcare, that we have populations among us that are receiving very, very different levels of healthcare compared to others. Totally, totally, only because of either their sex or the color of their skin.
Yep.
And I just think that's extremely important to point out because some of, especially my white male brethren out there, probably are ignorant to that idea or have never thought about that. But that's a really, really big deal in healthcare. And it's one reason why I was excited to talk to you about this topic in general, because women's health is incredibly underrepresented. And then when you get into issues related to how healthcare is, different for people of different ethnicities and things, it gets even more complicated. And
Absolutely.
so much of our research is, based on a very narrow and unrepresentative population.
Hmm. True. And a lot of let me give you an example. The bone density charts for determining, and the bone density tests for determining if you have osteoporosis or
Hmm,
not, they're based on European Caucasian women,
interesting.
and the parameters are for Caucasian women, but Black women, African American women tend to have a higher bone density. So we don't necessarily, you can't diagnose osteoporosis as accurately in Black women as you can with white women. Same with Asians.
Hmm.
Different bony structures. There is a difference. It's just because the norms, quote unquote, norm is a Caucasian woman. That's not the norm. We
Yeah.
need to change what we're basing our parameters on and make it so it covers more people.
Right. Yeah. And in your work with cannabis is dealing with women of different ethnic backgrounds. Have you noticed different responses or different nuances in treatment with cannabis that's worth bringing up?
Oh, the one I've noticed recently and it's just because I am dealing with this now,
Hmm.
is I've had a, a harder time treating pain in elderly Black women in particular, but elderly women in general.
Hmm.
If they've been on opioids
Oh, interesting.
and you're trying to get them to decrease their opioids or maybe even discontinue, cannabis, it's a lot harder to do. I've realized that. I do a lot of the little tricks like, okay, take your mostly they don't like to smoke, so they're
Hmm.
doing capsules or
Yeah.
tinctures. So I'll say, okay, let's take your cannabis with salmon or a fatty meal, or
Hmm.
let's take the tincture and put some more MCT oil in it so you can take it with something that's really fatty to help it absorb faster and get into your system faster. And that helps sometimes. You have to do more frequent dosing, but then you have to be careful that you're not causing too much psychoactivity or too
Hmm.
much that stimulation such that you increase their risk for falling or something to
Right.
that
Right.
effect.
Yeah.
So it's a tricky management that you have to try to balance both ends of it. And it's when I have younger patients, it's a lot easier to get the opioids down and have cannabis,
That's
have
great.
them more focused with the use of cannabis. Yeah.
Yeah, that's very interesting. And do you think that's related to like some structural changes that like long-term opioid use might cause that partnered with all of the other nuances that come with old age that's just causing some very different pharmacological activity or something?
Cannabis, again, it's multifactorial.
Hmm.
And if you don't have a good relationship or outlook, actually, you don't have to have a good relationship. Just if you look at cannabis in a negative light, like
Yeah,
a lot of
yeah.
these people were raised under drugs are
Hmm.
bad
Yep.
and all that sort of this is what it's going to do to your brain. So it's hard to get them to think of it as a helpful thing. And I
Yeah,
find
yeah.
that if your spiritual, mental, emotional aura or
Hmm.
energy is not amenable to cannabis or you're not receiving it well, it's harder for the cannabis to work.
Yeah,
Now
like
that
a
may sound crazy, but
well,
it's
it's like a nocebo effect. Hmm.
exactly what it is. That's exactly what it is. So I think it has to do with that. I also think it has to do with the fact that, okay, we know that imaging studies has shown that the cannabinoid receptors, as the estrogen levels decrease, the
Hmm.
cannabinoid receptors in the brain increase so that they have the receptors for cannabis and I mean for endocannabinoids, but their endocannabinoid levels are low
Hmm.
because their estrogen is low. Estrogen actually downregulates Fa
Ah, okay.
and increases anandamide synthesis. So it's doing what it can to increase endocannabinoids in our body, but when your estrogen levels are down, you're not getting that. So your receptors increase
Hmm.
because they're starved. So they're like, okay, we got to get more. We got to get more. So you would think that giving phytocannabinoids would be helpful, but who knows? It could be that the receptors are so starving that it just takes longer
Hmm.
to feed enough of them so that you can have an effect. Who knows what all this is about?
Right.
It's our knowledge is very, very limited right now, and we definitely need more research.
Yeah, absolutely. And that's so fascinating. That's making me think about how CBD would play into that too. You're talking about estrogen being a FAH inhibitor, and encouraging the production of the receptors. And I think about a compound like CBD that, at least theoretically, and this has been hard to research in humans, but in rodents and things, they've been able to show that CBD tends to also inhibit FAW, and
Yes.
and thus, if the endocannabinoids are being produced, or at least with anandamide, that they'll linger in the body longer. And there's been some evidence that CBD might also stimulate the production of anandamide itself, which is sort of a complementary feature to the effects of estrogen in getting the receptors boosted and getting that FAW inhibited. Have you noticed, I guess, unique clinical outcomes compared to using THC-rich cannabis versus CBD dominant products in that regard?
Actually, I find that is more of an individual thing. I think
Yeah.
what
Okay.
I've seen, type 1 chemovars, which THC dominant,
Hmm.
type 2, which CBD, THC 1 to 1, and then type 3 would be CBD dominant. I've seen all of them work on different people for
Okay.
similar problems. So it's really more individually
Yeah.
uh, manifested. It depends on the individual endocannabinoid tone. But one of the other things I do, besides with the elderly, besides asking them to take their cannabis with a more fatty substance,
Mhm.
I do also try to get them to eat foods that are endocannabinoid enhancing foods,
Oh,
like
great.
your chia seeds and your almonds, and foods like that, that are salmon is good, and things
Yeah.
like that. So yes, get your omega 3s up.
Yes, that's what I was going to say. Get those omega fatty acids up,
Hmm.
the basic
Hmm.
substrate for the endocannabinoids.
Exactly, exactly.
Yeah.
So we try to, try to do different things, but it can be difficult in some instances. But I will say this, my postmenopausal patients that are on hormones have a better
Hmm.
time with cannabis than the ones not on hormones. Not saying if you're not on hormones, cannabis isn't effective. Of course, it's
Sure. Yeah.
effective. It's just that I find it's effective. Uh, it's easier to titrate and find a dose when you're on hormones than it is when you're not.
And is that related to the dynamic you were talking about between cyclical hormones and constant hormones? Is that because
Yes.
they're on
Yes.
that constant regimen, so it takes some of that some of those dynamics out of the picture?
Right. Now, and yes, remember though that even on cyclical hormones, you still can do well with cannabis.
Hmm.
It's just that there may be times when your dose needs to change, or the frequency of use needs to change,
Hmm.
because of the fact that in a menstruating female, the menstrual cycle, the amount of anandamide, your
Hmm.
endocannabinoid circulating, is higher during the follicular phase. That's the first half of the menstrual cycle. Is highest during ovulation and is lower during the luteal phase. So that you may find yourself not requiring as much cannabis if you're during the first half of your cycle, and then needing more cannabis in the second half of your cycle, which is called the luteal phase. So not everybody, it may not even be the majority of women, but some
Hmm.
women will have that experience, and it isn't abnormal. That's the reason I'm
Hmm.
highlighting it. It is not
Yeah.
abnormal to have to change your dose depending on your cycle. And it's
Yeah.
really an observant woman who will even notice that that's happening.
Yeah, absolutely. And this actually plays into something that I talk about a lot, which is I anybody that is wanting to understand how cannabis is affecting them, I always recommend keeping a journal, so that you can at least keep track of what you're taking, when you're taking it, collect some basic information that you can share with the physician or whoever you're working with to try
Mhm.
to see those patterns as they come out. And I think that's extremely valuable for so many people listening to understand that, um, if you're a woman, you need to pay attention to your dose a little differently than if you're a man. And something that I've wondered too, have you treated any trans patients that are taking hormones, going through like transition therapy or something, and dealt with any of this?
Interesting question. I just read, no, I haven't treated anyone, but I just read um, when I was looking into the sex differences, cannabis use in men and women and sex
Hmm.
differences. And one of those differences is that men use cannabis more than women, use higher doses
Mm.
and more frequent use.
Hmm.
But I think that's going to change. But anyway, that I'll get
Yeah,
to
I
that
think so too.
shortly.
Yeah.
But a study conducted in 2017 had it consisted of over 1,200 transgender adults,
Hmm.
and out of them, 24.4% were cannabis users, and cannabis use was significantly greater among transgender men compared to transgender women, which I
Wow.
thought was fascinating.
Huh. Wow.
Yes, fascinating. So that's another part of the puzzle, another piece that
Hmm.
we need to look at. When we're doing studies now, we have to look at gender differences, and I'm talking trans,
Yes.
bi, cis, all the pansexual, all the new gender definitions. We have to look at that and see how they apply. It's not just male, female anymore,
Exactly. Yep.
you know?
And that's something I really wanted to be careful to point out, because we have this like simplified way of saying, how does cannabis affect women differently than men? But what I really wanted to hone in on, and once again, why I'm so happy to be talking to you about this, given that your focus is on hormones, is that this is really about hormones
Hmm.
more than whether someone identifies as a male or female. It's what is the chemistry of your body, what hormones are at play in your physiology, and how is that going to relate to cannabis use. And it's something that has been on my mind a lot because, I mean, one, all of this medical cannabis stuff is so new. But then also, this expanding our consciousness in terms of how we think about gender and sexuality and stuff is, I wouldn't say it's new, but as far as how far along it is in mainstream consciousness, we've definitely come a long way in a short amount of time, even though we have a lot further to go. Um, and that's affecting medicine on so many different levels. And I haven't heard one person talk about how cannabis affects anyone that is outside of the typical binary for gender identity. So that'll be really interesting research to see in the future, how cannabis affects people differently in those sort of um, hormonal situations that we're not accustomed to thinking about a lot. And it's going to be
Exactly.
really important because doctors are going to be working with patients like this, sometimes maybe without even knowing it. And if they're working with cannabis, these are really important
Mm,
nuances to understand.
they are. And it, for me, it's a newfound freedom to
Hmm.
see people living their truth
Yeah.
and not being ashamed to live their truth. I find
Hmm.
that very powerful, very empowering for myself as
Hmm.
well as others, because it's a wonderful thing. And yes, that means we need to incorporate that in our research.
Yep.
We can't. It's a population that can no longer be ignored. It just can't.
Absolutely. Absolutely. Yeah. Yeah.
Yeah. So, speaking of male female differences, and I'm not the moderator, so I guess I shouldn't do that.
No, no, go for it. Go for it.
But, in how cannabis affects men and women differently, there was uh, a study, a few studies, I'd say 10 or so years ago, that talked about uh, the actually, I'd say probably less than 10 years ago, but it talked about male and female differences. And they talked about how men use higher doses. They're four
Hmm.
times more likely to try cannabis. They prefer joints, blunts, vapes, and concentrates, whereas women use cannabis less frequently and in lower quantities and prefer oral administration or pipes.
Hmm.
And that is being blown out the window because I think it was more of a societal thing.
Yeah,
I,
yeah.
it,
Hmm. I agree.
two things tell me that in the month of March, dispensaries reported more women bought more cannabis, spent more money in dispensaries than men the month of March
Oh,
2020.
I did not realize that. Wow, that's
Exactly.
fascinating.
And I just did a study. It's a survey. It's not published yet. We're in the process. We're analyzing it. But I looked at the routes of administration and the men and the women. And we had 528 men, 782 women. And as far as smoking flower and or weed, so to
Hmm.
speak, where it was thought that men did that more than women, 40% of women smoked weed, 42% of the men smoked weed. That's about equal as far as I'm
Yep,
concerned.
yep, yep.
Now, women do use topicals a little bit more than men, and they do use tinctures a little bit more than men. But there, as far as vaping, women vape more than men, and they used to say that men vape more than women.
Mm-hmm.
So
Yeah,
I think a lot of those societal things are changing as far as the usage is concerned. I think that is,
yeah.
like I said, a more cultural, societal question. Where sex differences are going to really play a role is with cannabis use disorder,
Mm.
and that is because women do, even though more men are uh, diagnosed with cannabis use
Hmm.
disorder,
Yeah.
females have a shorter onset from cannabis use to cannabis use disorder,
Oh,
meaning women go from their first use to cannabis use disorder a lot faster than men do. And women have more severe withdrawal symptoms than men do. And
interesting. Wow.
yes, very interesting. I think that's where you're going to find the differences. None of this stuff about different routes of administration and the reasons and whatnot. Uh, there was even one report that said, and I got to say this because this is the most ridiculous thing I've ever. It's very sexist. It said women have a desire to clean when they're high.
Oh boy.
Like really, like I have a gene that tells me that it's time to clean. Really?
Oh,
I
I
know.
just smoked. Now I got to go clean the house and make
Yeah,
dinner, I guess.
exactly. It's like, honey, that's the last thing I want to do.
Oh, wow. Wow.
But see, that shows you how sexist
Oh boy.
and the studies were. The people looked at things just wrong.
Yeah.
And but like I said, women and men in cannabis use disorder, there's something to that because we do transition from first use to cannabis use disorder very, very quickly. And they call that uh, telescoping. It's like
Yeah.
it's Zoom right there. And there's no differences in age at first use or
Hmm.
heavy use or age of the onset of cannabis use disorder or total number of episodes of cannabis
Hmm.
use or in the number of criteria. All that is the same. It's just that transition from
Hmm.
onset of cannabis use to onset of cannabis use disorder, and the fact that we have more severe withdrawal symptoms.
That's the part that's really fascinating to me because the diagnosis part, to play devil's advocate, you could say, well, maybe women are more likely to communicate or seek treatment more than men for whatever reason, or there could be some explanation of that because a lot of people are very uncomfortable with the idea of cannabis use disorder, particularly people that are very active in the industry. They don't. really like to talk about it that much, but it is something
Mhm.
we need to talk about. But the withdrawal part goes deeper than maybe some possible variables that someone's not keeping track of that shows a distinct pharmacological difference um, that is, I think, a lot harder to criticize. And maybe I'm wrong, but as far as how I'm thinking about it right now, that's a lot harder to criticize than the other side of just how many diagnoses there are. Um, so that's
True.
extremely interesting, and it's something I need to find some people to talk to about cannabis use disorder. I've got one friend that is a substance use and addiction expert that I want to talk to, but that's a concept I want to explore more because I get questions about it, and it's just tricky to talk about. Uh,
It is. And I don't have any scientific basis for saying this. It's just from the material I've read and clinical experience. I, I really feel that the concentrates are
mhm,
what leads to cannabis use disorder, not all the regular smoking, vaping, edibles, all that sort of thing. It's mainly the concentrates, the power packed THC.
mhm,
That I believe is what's causing cannabis use disorder to emerge. Because I don't, cannabis itself, it's been for years and years and years, and addiction is not a problem.
mhm. Yeah,
Uh, 9 to 10% addiction rate when you look at nicotine being almost 30% addiction rate.
right.
So,
Gambling. I mean, there's like
right,
non drug behaviors that are more addictive. Yeah,
exactly. Even your ingestion of sugar.
yeah, yeah,
Sugar is
absolutely.
more addicting than cannabis.
Yeah,
So it's it's just the it's if you look at when we started, when concentrates became prevalent, and look at diagnoses such as cannabis use disorder, and see where that correlates. I think you'll find something there,
yeah.
because that's all I can say. And I don't have a scientific basis, but it's
Hmm.
just a,
A
like I
hunch.
said, a speculation. Yeah, a
Yeah.
hunch.
Well, it's a hunch that I share just from some of the teaching that I've done. I'll never forget that I taught one workshop where we were talking about cannabinoid toxicity, which, is really low. But one thing I mentioned was the effects that some of the synthetic cannabinoids have on receptors and how long-term THC use, especially at high doses, very frequently, how that can alter receptor expression and that sort of thing. And I had a student come up to me after the workshop and said, "I've been smoking dabs every 2 hours for the past 5 or 10 years," and
Wow.
I was blown away. I For a second I didn't even know how to respond. I was like, I okay. Uh, I was like, it might be interesting to do an abstinence break and see, how your body responds if you gave it a break. And because we talked about ways to nurture the endocannabinoid system and the importance of, if you are a chronic user, of taking some breaks, eating
Mhm,
some of those
mhm.
fatty foods, getting some extra virgin olive oil and stuff in you, and give your body what it needs to make more of those receptors and make more endocannabinoids and everything. And so this person was very concerned, but that really opened my eyes. I live in Oregon. I've been exposed to the dabbing culture for a while,
Mhm.
and I know how prevalent it is. I see on Instagram and YouTube people doing ridiculous things, um, but just hear somebody like vocalize that, every 2 hours for years.
That's pretty amazing. They must not do anything else.
Well, no,
I
or
don't know how you have time to do anything
I know,
else.
yeah. Well, and it's gotten to this point too where, that was their baseline of functioning.
Oh,
Um,
wow.
and so, yeah, I don't know. It was a hard kind of conversation. And then they came to me later and said that they took a break for a little while, but um, they had just gotten so used to the sort of punch that concentrates packed in that they didn't really like flour anymore, and they didn't really like anything else, and so they just went back to doing that. And I was like, well, you know,
Wow.
be careful. It's the best I can say.
Yeah,
Um,
that's all you can say.
yeah,
And
but
maybe it's that can be expensive though too, can it?
well, out here in Oregon, depending on who you know, you can get pretty free access to large quantities of
Okay.
cannabis products and stuff. So there are some people that live out here that are basically never have to spend money on cannabis, and so it creates those sort of scenarios. But that's something I've definitely wondered. With the dabbing culture as it is, getting high concentrations of THC hitting the brain frequently. I once again, just like you, I don't have science to say one way or the other, but my hunch is that's probably not good for you.
Yeah.
but
Probably not. You're right.
but um, shifting gears just a little bit because I don't want to
Mhm.
keep you forever. You've been really gracious with the amount of time you've been willing to spend talking with me so far. I wanted to make sure that we talked about fertility, another side, to this whole sort of puzzle that we've been talking about with men and women's health. Can you speak a little bit about how cannabis, at least as far as what we know so far, how does cannabis affect fertility in men and women? And I'd also like to hear your thoughts on cannabis use while breastfeeding and that sort of thing too. So I think there's probably a lot of women with questions about that.
Sure. As far as fertility is concerned, we really don't know if cannabis affects fertility, uh,
Hmm.
and if it does, how it affects fertility. Animal studies suggest that it should affect fertility since the endocannabinoid system is so intimately involved in uh, fertilization and growth of the fetus of the baby. We know that there's three developmental stages in which the endocannabinoid system plays an essential role uh, for survival of the fetus during early gestation, the uh, embryo passing through the tube, the oviduct, and then planting into the uterus requires critical enzymatic control of the endocannabinoids, specifically anandamide. And then during fetal life, the endocannabinoids and CB1 receptors are important for brain development, important for guiding the synapses of the axons and migration of the axons. And it also helps regulate, helps the development of the neural cells into the neural subtypes and supporting glial cells. So, and then postnatally, CB1 activation by 2AG is required in order to initiate suckling. So you would think that any disruption of that will cause a fertility problem. But we really haven't seen that, haven't been able to show that in studies. It hasn't been borne out, like I said, in human studies. Maybe some animal studies, there may be some, but not always. So, and cannabis use is always on the list of things that affect fertility when couples are going to fertility physicians. They'll say, if you're
Yeah.
smoking cannabis, you need to stop. The, Dr. Michael Eisenberg out of Stanford did a study in 2018 looking at cannabis using couples versus non cannabis using couples and followed them to pregnancy. And he found no difference in either between the two groups in the time it took to become pregnant.
Hmm.
So, and that was in 2018.
Yeah.
So it's just not it's not clear.
Hmm.
Like I said, I understand why someone would say that,
Hmm.
but it's not quite clear that that happens. And the one thing we forget about cannabis is that there is a such thing as tolerance.
Hmm.
Humans experience tolerance to cannabis, so that some of the initial effects of cannabis, when you have tolerance, you don't feel them.
Hmm.
But that doesn't mean that cannabis isn't effective.
Yeah.
Tolerance is great because it allows you to experience symptom relief while
Hmm.
being able to function, which is key to the whole use of cannabis. You want to still be able to function and be a productive, contributing citizen of society. So
Of course.
we all strive to do that.
Well,
but but really, tolerance is a good thing, and maybe tolerance is there to protect us. Who
yeah.
knows?
Yeah.
So, with respect to fertility, we don't know, but every fertility, if you go seek the advice of a and management from a fertility physician, that's one of the things they're going to tell you: stop smoking cannabis.
Hmm.
When there's no proof that that really is a problem. Now, as far as pregnancy and breastfeeding, let me say this. I'll say this first. The
Hmm.
best things for pregnant women to ingest are healthy whole foods, clean
Hmm.
water, and fresh air.
Yep.
Limit white sugar, avoid processed foods and foods with no nutritional values, and it's advised not to ingest or smoke drugs of any kind, including tobacco, alcohol, caffeine, cannabis, pharmaceuticals, opiates, methamphetamines, etc., while pregnant.
Hmm.
Now, I got that memorized because that's part
Of
of my
course.
spiel.
Right. Got to. Yeah.
That's part of my spiel to my patients. And there is really no known safe or unsafe amount of cannabis that should be used in pregnancy.
Yeah.
Now, let's look at what the science says because the science is all over the place. There's really, I'll start with the NASM report of January 2017. It reviewed over 10,000 studies, and there was an entire chapter on prenatal, perinatal, and fetal outcome in cannabis use. The only definitive finding in a good quality study was that of lower birth weight.
Yeah. Yeah.
And that was attributable to the smoking of cannabis. Probably more, I should say, it was attributed to the smoking aspect rather than the cannabinoids.
Hmm. Maybe
So,
carbon monoxide.
right, it's shifting of the hemoglobin dissociation curve. You remember all that stuff in physiology?
That
Oh,
I try to forget on a regular
I
basis.
know. It rattles my brain even if I say it. But a lot of the problems with the studies is they aren't looking at pure cannabis use.
Hmm.
It's always compounded with alcohol,
Hmm.
other pharmaceuticals, smoking. Smoking is a huge compounding um, factor. So you're not getting a true reading. Now, there is the one study that was done on pure cannabis use, and that was the Melanie Dreyer study, which is still is one of my faves, and a study from which we should be building, upon which we should be
Hmm.
building from instead of poo-pooing it.
Is that the Jamaican study?
That's the Jamaican
Yeah.
study,
Yeah.
exactly.
Hmm.
Um, this is the key that people often overlook. This area of Jamaica was rural Jamaica, and they grew their own food.
Hmm.
They used cannabis as a medicine and as a spiritual uh, aid, and they didn't take a lot of pharmaceuticals, and they didn't drink a lot of alcohol or smoke a lot of cigarettes.
Yeah.
Didn't really do much of that at all, actually, at that time of her study. And the women drank cannabis teas. And there
Hmm.
was a small subset of women that smoked cannabis, but the majority of women did the teas and the salves and things like that. So you're looking at a different population, a population who was probably eating really good food. Their physical bodies were not necessarily contaminated with anything else. And they had, there really weren't any differences between the cannabis exposed babies and the non exposed, the babies not exposed to cannabis, except a few of the cannabis exposed babies uh, were what we call more satisfying, kind of had better physiologic stability, however
Mm.
she measured that. And
Mhm.
she did bring in independent examiners to do the examination. So it wasn't the
Yeah.
people involved in the experiment and running the experiment doing the examining as well. So that was really one good part of another good aspect of the study. But all the other studies, the Peter Freed study that followed kids from
Mhm.
gestation all the way till they were 22 years old. Then there was the Goldschmidt study that followed them from gestation to 14, and then all other studies showing that there were some adverse effects. They really weren't clear on that, and all of
Mhm.
them had the limitation that there were confounding factors like cigarettes and alcohol. Some of the studies actually showed where the combination of cigarette smoking and cannabis smoking what provided a synergistic effect such that some adverse effects were worse than
Uh,
if you did
mhm.
cannabis smoking alone or cigarette smoking alone. We know cigarette smoking has adverse effects. We really just don't know if cannabis smoking, besides the lower birth weight, and to some moms, lower birth weight is great because
Yeah, yeah, especially if it's your first baby.
exactly, exactly. You don't have to feel so terrible. But I'll tell you a recent study, this study was just published. I've been waiting for this study. This group, it's a group out of Columbia University in New York. They had a poster presentation in 2017 in which they looked at all the studies that looked at cognitive impairment
Mhm.
related to prenatal cannabis exposure. And they found that less than 10% of the studies actually compared the results to the normative.
Ah.
Well, this team went and did that. They looked at all those old studies, found those tests, compared them to the normative. They looked
Wow.
at more than 1,000 studies and between groups that were exposed to cannabis prenatally and non-exposed controls. And those exposed performed differently on a minority of cases. They were worse in less than 3.5% of the time, better in less than 1% of the time. So but the majority of the time, there was no difference.
Mhm. Yeah.
So
Wow.
this
Wow.
this shows you that
Mhm.
maybe cannabis doesn't impact the the baby's
Mhm.
cognitive achievements and accomplishments as we're thinking it does. So it's I'm just overwhelmed by that. I really
Yeah,
am excited.
absolutely.
Actually, I picked up the phone and called one of the authors because I called him about the 2017 poster. And as soon as I got this study, I said, "Oh my gosh, you guys did it! You did it!"
Finally, someone did. Yeah.
Exactly, exactly. So, getting back to using cannabis during pregnancy, no, I don't generally recommend it, but I know there are circumstances now in which cannabis can be considered harm reduction,
Mhm.
and cannabis use in hyperemesis gravidarum. That's a woman who is in early pregnant, just can't stop.
Yeah.
The nausea and the vomiting are persistent, and she's suffering weight loss. And before you put her in the hospital on IV therapy and all the complications that go with that, let her have a toke or two of cannabis on a regular basis and she'll be fine. So that's harm reduction.
Yeah.
If they're already using cannabis to control their seizure disorder or treat their PTSD or whatever medical condition and they become pregnant, then there's a management issue. And you do what I do is I counsel patients, uh, counsel, tell them about what the studies tell us, what they don't tell us. I ask why they're using cannabis. If there's a safer medication, we can switch to that. But if there isn't, and oftentimes there isn't, that's why they're on cannabis,
Mhm. Yeah.
I would ask them to use the lowest effective dose
Yeah.
and see, okay, let's look at this now. Cannabis, let's look at it as a medicine. We only take it when we need it, and we
Mhm.
use the lowest effective dose. This is not the time to smoke to get high or use cannabis just because you stayed up all night and now you want to sleep, so you just get some cannabis so you can go to sleep during the day. No, while you're pregnant, we don't need to do that. But the it's just it's counseling, it's non-judgment, it's
Yeah.
caring, it's keeping the lines of communication open. And I'll conclude my answer with this. There is no reason on this earth to threaten a pregnant woman who uses cannabis with taking their child from them or incarceration or even the slightest disruption of the family just because of cannabis use. There's no reason for that at all. And I will stand firmly on that. And I will testify on behalf of any pregnant woman who this happens to.
Yeah, that's very, very awesome to hear. It's something that I've worried about. I don't know what the statistics look like on that, but it is something I've worried about, that as cannabis gets legalized and medical cannabis gets legalized across states, there's not a lot of guidance from um, state health agencies about what will happen if you're a pregnant woman or you're nursing and you're using cannabis, and let's say your child injures themselves for some reason and they get some blood work done, and maybe for some reason they do a toxicology screen and cannabinoids show up, in your child. What happens then? um in different
All sorts
states.
of terrible things happen,
Yeah.
unfortunately.
Yeah, and I
It's
mean, it largely depends on where you live, because it
yes, it
depends
does. Yes,
on
it does.
how how strict, some of that is interpreted. But it breaks my heart thinking that anyone out there, that has been using cannabis in a responsible way, and that has found that it, is helping improve quality of life in some way, and ultimately it's not harming anything, um, that they have to worry about having their entire families disrupted or having their children taken away. I mean, especially being a parent now, if someone were to come and try to take my child away, you know,
Exactly. Those are
um,
fighting words. It makes you wanna do
yeah,
things that you never thought you would do.
exactly,
Yeah,
exactly, yeah. And to base that kind of action on science that's just not there, that
exactly.
it's more about stigma and bias and all these other things than it is science. um, it's a real problem that we need to be talking about. And for anyone listening that might be more of an activist than I am, because I'm more of just a teacher. But for those that are really, talking with legislators and other things like that, if you're involved in a state that is in the process of changing law, like that is something that needs to be talked about. That, how do you handle pregnant and nursing moms, or parents in general that have kids, and cannabis is legal? How do you handle that? And provide good guidance to families so that they're not operating in the dark, terrified. And then also the jail problem. How do you handle your
Yes.
incarcerated populations that are in jail for nonviolent drug offenses that now you've got a whole economy based around? Those two things that I just hope people realize how serious those two issues are, and that those are getting addressed as we're rushing to open up pathways for cannabis to be accepted as a sort of normal
Yes. Very,
commodity.
very yes, that's all very, very true. It's just we have to be reasonable. And I will say this to anyone out there: if they need anyone to come and testify, if they want a passionate
Yes, yes.
physician who will come and speak truth, just contact me. I'll be there for you.
Yeah, yeah. Well, that's excellent, excellent resource out there. Well, we've been going now for probably about an hour and a half
Oh,
or so. It's been
okay. Oh my
we've
goodness.
we've covered so much ground. I think there's a lot here that people can learn from, and uh, honestly, a lot of sort of philosophical stuff here for people to chew on as well. So this has been a really great pleasure for me. I wanted to, in our last few minutes here, basically open up the platform for you. If there are any topics we haven't covered that you think are really critical that we should go into, we can do that. Otherwise, I want to give you the platform to let people know how to learn more about your work and like the Society of Cannabis Clinicians and all the other different things that you've kind of got yourself involved with. Let people know how to learn more and how to find you.
Oh, thank you for this opportunity. Boy, the time flew.
Oh,
That's
I know.
really
Yeah.
amazing. Here I was worried. Oh my gosh, what am I going to say? What if I run out of things to say? Oh no! But this just flowed very nicely. You are easy to talk to, Jason,
Oh,
and
thank you. I appreciate that.
the conversation really did flow. But certainly, there's a lot more we could talk about as
Oh,
far as
yes.
women's health. We can get very talk about specific conditions and things, but there's other times for that. We can
Yeah.
nothing that says we can't do this again.
Exactly. Yeah. Exactly.
So yes, I can. My website is victoryrejuvenationcenter.com. That's victory, VICTORY, rejuvenationcenter.com. My email is drwilsonking@drwilsonking.com. That's
Easy
all
to remember.
lowercase. Yes, DRWILSONKING, all lowercase, no spaces or punctuation, at the same thing.com. And yes, I'm involved in a few things. I've done expert witness testifying for cannabis criminal cases. I am co-vice president of the Society of Cannabis Clinicians, which is an organization that's dedicated to the education and of physicians and patients about cannabis, and especially clinicians. We want all clinicians to be prepared, and
Yes.
we have
Yeah.
a really good CME module, and we're redoing it now. There'll be a brand new one by the end of the year. I'm also a board member of the Doctors for Cannabis Regulation, which is an organization that is focused on social justice and helping states formulate their medical cannabis programs such that minorities can be a part of it,
Great.
and to include social justice
Hmm.
uh, protocols and policies.
It's
Because
conveniently left out when a
that's
lot of these
right.
laws change.
And the brown and black people are the ones who led the way as far
Yep.
as cannabis is concerned. And they were the pioneers, and they're in jail now because of
Yep.
it. And uh, the non people of color are capitalizing off of that. And there's
Yep.
something wrong with that. I
Very
think
much so.
the state of California, specifically the city of Oakland and San Francisco, are trying to right those wrongs in
Hmm.
some very uh, creative ways. And one of which, not so creative, but how about not letting an arrest for cannabis possession stop you from being involved in the cannabis industry? It's like,
Yeah.
come on, that's not a violent crime. They shouldn't be. They should still be allowed to participate in the industry that they helped to
Yep.
populate, create. So that's near and dear to my heart. Uh, the care of women is definitely near and dear to my heart, and uh, I am. I don't toot my horn enough. I really don't, but I will say this: I am considered an expert in women's health in relation to cannabis and in relation to hormone treatment. So uh, I'll be willing to answer questions and do consultations. No, I don't prescribe cannabis to, or you don't prescribe cannabis anyway. Cannabis is
Right.
recommended, and I
Yeah.
don't recommend cannabis, I can't give you a recommendation unless you're a resident of the state of Florida.
Yeah.
Uh, but I can do I do educational consults and can give you the information you need to do it legally where you live.
Yeah.
So feel free to reach out if you have any questions or concerns, or if there's anything which I can be of service to you.
That's great. Yeah. And I'll make sure to toot your horn for you wherever I go. Make sure people know what your specialties are and that you are that resource for the community. I'll make sure to help you that way.
Oh, cool. Thank you, Jason. I
Yeah,
think next time I do this, maybe I will show myself.
there you go. Yeah. Well, yeah, and like you said, we kind of kept it on the a sort of high level with this discussion. Talking in broad terms of, about women's health and fertility and all these different things. But absolutely, there are so many specific topics we can go into, and I'm happy to drop in with you anytime you like to go into any of those or all of them. Of these, more specific areas. And one thing that we didn't really get into that might be worth discussing in another episode is something that my wife deals with, and she gave me permission to talk about her on the show, just so everyone knows. Uh, she was like, by all means, bring this up because more people need to think about it. But she deals with several things that we feel like there's no way they're not connected. She has really bad migraines. She has dysmenorrhea and insomnia. And all of those problems got better after she had our daughter, and her hormones changed, during that time. And then as her body stabilized after about a year, after giving birth, it's all coming back in full force. And it's interesting, and something that it would be interesting to discuss with you is the connection between these these groups of symptoms that we often separate, that are probably, we touched on a little bit, but that almost certainly overlap and are highly, highly influenced by hormones.
You said it was migraine headaches.
Migraines, insomnia, and dysmenorrhea.
Oh
Like
yeah.
pretty
Oh
severe
yeah.
dysmenorrhea. Yeah.
Oh, we can talk about that. Absolutely. Does she use cannabis?
Um, Occasionally it depends. She's very sensitive. Um, and that's another piece, to that puzzle that plays in there. Um, but sometimes, and the relief she gets is hit and miss. But she also hasn't tried to really explore it in a very like serious, sophisticated way of like playing with modulating dosaging or anything. She's not quite there
Mm-hmm.
yet.
Mm-hmm.
Um, but yeah, it's something that before coming in this interview, she was like, bring that up and just see if there's some hormone issue with that. And I was like, well, I can tell you just from what I know that there's got to be.
Yeah, she needs a hormone panel,
Yeah.
and you have to do that at a certain time in the cycle,
Mm,
and check the hormone levels, and it'll tell you the story just by doing that. But you have to be trained in
hmm
how to assess that, what tests should be ordered, when they should be ordered, and then how to assess them.
Yeah.
Um,
Interpret. Yeah.
and we can find, yes, we can find out. I think I know what it is, but I would like to do
Yeah.
the
Yeah.
testing to confirm. But yeah, I can probably tell you what it is.
Yeah, yeah.
Uh,
Well, like I said, that's something that maybe in a follow-up episode we can talk about these concurrent issues, that some people are dealing with, and this ties into the endometriosis thing too.
mm-hmm.
That I think there are a lot of women out there that are struggling to get. Now that I'm thinking about it, I'm like, geez, I know actually a lot of women going through similar things, but that are trying to get help with a medical issue that is being isolated from the bigger picture. And so I think just talking about that interconnectedness, and how imbalances in the endocrine system, and how that ties into the endocannabinoid system and all that, can present this mosaic um, of symptoms, which, even Ethan Rousseau, just in his paper about the clinical endocannabinoid deficiencies, linking together like irritable bowel and fibromyalgia and stuff like that, it kind of touches on this idea that when the endocannabinoid system is out of whack, you can sometimes have groups of symptoms that seem like separate diseases and could all just be one
And they
thing.
are interconnected.
Yeah.
Exactly.
hmm
Exactly.
So
And
any
maybe what we could do is uh, let me interview her, and make some recommendations and see what happens, and then that's something we can talk about on the next podcast.
Yeah,
What we did and uh,
that'd be great.
if it helped or not, and kind of walk through the process.
I'm sure she'd love that. Yeah, that'd be great. I'm sure
Yeah,
it would help a lot of people too, just to hear about that process. So yeah,
sure. I'd be
I'll
more
talk
than
to her
happy
about it.
to do that. Okay, very
Awesome,
cool. Well, this
awesome.
was great. I can't believe we spent this much time together.
This
Oh
is this
my
is
goodness.
this is what happens, and that's when I prepare people for the show, I always say we're gonna have a conversation. It's not gonna be the type of formal interview that you might be used to,
Hmm.
and that's my goal as the host, is to try to make this easy, comfortable, and have the time melt away. And before you know it, our listeners have learned so much without even realizing it.
Well, you've done a really nice job, and it was not painful at
Excellent.
all.
Excellent. Yeah, I never want it to be painful. Um, well, everyone that's tuned in here, go check out Dr. Wilson-King's work. Go check out the Society of Cannabis Clinicians, and what was the other group? The social justice group.
Doctors for Cannabis Regulation,
Doctors for
DFCR.
Doctors for Cannabis Regulation. Check
Yes.
all of those groups out. And if you want to learn more about Curious About Cannabis, you can check us out at cacpodcast.com. You can also find us on Instagram, Facebook, Twitter, and YouTube. And if you're interested in supporting the show, as you may notice, we don't take ads and we don't deal with sponsors to try to maintain integrity in this crazy industry. So if you want to support the show, you can become a supporter at patreon.com/curiousaboutcannabis. And there's all sorts of little ways that I try to find to thank our supporters there, exclusive content, things like that. So if that interests you, feel free to do that. And other than that, thanks so much for tuning in. Take it easy, stay curious, and I'll catch you next time. If you want to learn more about cannabis, you can check out the Curious About Cannabis book, available now on Amazon.com and other online book retailers. The Curious About Cannabis podcast is presented by Natural Learning Enterprises, a science education company dedicated to the enhancement of public scientific literacy through education about the natural world. Curious About Cannabis is just one of several learning initiatives produced by Natural Learning Enterprises. To learn more, go to www.naturallearningenterprises.com or connect with NLE on Facebook, Instagram, or Twitter.